We finished this slide.
Yes, yes.
I think we finished diuretics.
Doctor,
It's finished. Doctor.
why are we taking diuretics again? We took it before.
Because for this reason, you see, we have just taken one slide. One of the important use of diuretics, that they are used as anti-hypertensive. They reduce blood pressure. So even if you take your case that you have taken last week and you will complete today, the patient was suffering from high blood pressure or hypertension, and initially he was placed on one of the thiazide diuretic. So for this reason, but here we just covered it in one slide. Yeah, we have finished, I think, diuretics. Yes, no?
No.
We didn't start it? No, no problem. So we have already discussed it in diuretics. Here, just briefly, there are many groups as we discussed in renal module, but the three important diuretics that we use in our clinics to reduce blood pressure. First group, that is the thiazide diuretics. The latest two that are also, they act by the same mechanism. First one is indapamide and the second one is chlorthalidone. As if you recall, we discussed previously, there are different segments of nephrons where the diuretics act. Like if it is closer to the Bowman's capsule of our glomerulus, then we say proximal convoluted tubule, then loop of Henle, then distal convoluted tubule, and then collecting them. Thiazide diuretics, because they are the moderate diuretics. Moderate means that their diuretic effect to produce urine is not very high because they act in the distal convoluted tubule. So, first thing, that they are moderate diuretic. Second important thing, that their duration of action is not very prolonged. So we need to repeat the dose, especially with thiazide like bendrofluorothiazide or hydrochlorothiazide. The new one, what we say indapamide and chlorthalidone, the dose of chlorthalidone and thiazide is almost same, 50 milligrams. Both are given 50 milligrams. But the good thing about chlorthalidone, that it is long acting. Chlorthalidone, this one, this is long acting. We just need once a day dose. For example, you have a patient and diagnosed with hypertension, we will give just morning dose. We don't need to repeat the dose. Why? Because chlorthalidone is long acting. Same is with indapamide. Indapamide is not only long acting, but it is also potent. We need smaller dose, like 1.5 milligram is equal to 50 milligram of thiazide. So quite a big difference, you can say almost 25 to 30 times more potent as compared to thiazide diuretic. If you recall, even we discussed the side effects. There are side effects like hyperglycemia, hypertriglyceridemia, hyperglycemia, hyperuricemia. These are the side effects. Why we are concerned about the side effects of diuretics? Because you see that patients need to use them for lifetime. Hypertension is not headache. Hypertension is not fever. Hypertension is not infection that you have and within 1 week it will go away. It is lifetime problem. So the patient needs to take the drug for lifetime. So if the patient is taking these drugs for a lifetime, there are more problems that we face. The side effects are more. Again, if you get question on your exam that which one of the following is the potent in thiazide or thiazide-like diuretic. So the answer should be indapamide.
Indapamide.
Okay? If we say the longer duration, then it is chlorthalidone. Chlorthalidone, the duration is longer, we just take it once a day. The second group, that is potent diuretic, because it acts in the loop of Henle. And loop of Henle is thick ascending loop of Henle where the urine is concentrated. So when the urine is concentrated, that means there will be more sodium electrolytes in this segment of the nephron. And if you recall, I told a simple formula, sodium goes, who goes? Water goes, very good. Sodium goes, water goes. Sodium goes, chloride goes. Sodium retains, water retains. So because in the loop of Henle there is more concentration of the sodium, so more sodium is going. So more sodium is going means more water is going. So this is potent diuretic. And one of the loop diuretic that we use in our clinics, that is furosemide or furosemide. So that is very commonly used. There are also other we discussed last time, bentonide, torsemide, they are longer acting, they are used in certain other conditions also. The one that you will see in your clinics downstairs and inshallah later on in your own clinics, that is furosemide. Furosemide is quite commonly used. It is not longer acting like chlorthalidone that you just take once in the morning and finish. No, you need to repeat the dose maybe in the afternoon. But the good thing that it is potent diuretic. It causes maximum diuresis. Another good thing, even we discussed last time, that it acts even in lowest GFR, because the use of diuretics is based on GFR, or glomerular filtration rate. If the GFR is less than 50%, the only diuretic that we use, that is furosemide. So if you get question on your exam, which of the following diuretic is used in lowest GFR? Then the answer should be furosemide. Furosemide is used even in lowest diuretics. So what is the mechanism of action? There are two mechanisms by which it will reduce the blood pressure. The discussion that we already done, that was about diuresis or urine production. Here, how we can correlate it with the antihypertensive activity. First one, it will reduce the plasma volume. And plasma volume will be reduced by two mechanisms. First one, it will cause decreased preload. What do we mean by preload? Preload. The blood that comes to the heart from
non-oxygenated blood.
lungs, preload. Which cells carry blood that goes there?
Red blood cells.
Venous return, venous return. What do we mean by venous return? Which veins take back the blood to the heart? There are two types. You already discussed. You know it, just recall. Superior
vena cava.
and inferior vena cava. So that is called venous return. The blood that is going back, that is called preload or venous return. So it will reduce the venous return. Why it will reduce the venous return? Because it is taking away the fluid from the body. So when you take away the fluid from the body, water and sodium, so it will reduce the preload. Second, it will decrease the cardiac output. If you remember, we discussed last time, what is cardiac output? CO is equals to human resources into SV. SV means,
Systemic vascular resistance.
yeah, doctor. SV, stroke volume. Stroke volumes. Stroke volume, and HR is heart rate. So it will reduce both heart rate and stroke volume. Why? Because of its effect on the stroke volume. There is less blood is coming to the heart, so it will also affect the stroke volume. So that will decrease the cardiac output. Second one affects smooth muscle tone, as you say, SVR, R smooth, this systemic vascular resistance. It will decrease total peripheral resistance. When the cardiac output is reduced, the afterload is reduced. Afterload means when ventricles send the blood to the body. So left ventricle send blood to the aorta. So what will happen? Less blood will go to the aorta. So that will reduce the systemic vascular resistance, or what we say peripheral resistance. So that are the two mechanisms by which it will help in reducing blood pressure. Again, if you recall, and hope you already discussed with your doctors in PBL, whenever we have hypertension patient, we need to take 3 different readings. We just don't start with first reading unless it is very high blood pressure. Like you have a patient in your clinic and you measure the blood pressure, and the blood pressure is 200 over 120 mmHg, and you ask the patient come next week. No, this is too high. But if the blood pressure is, for example, 145 over 90 mmHg, okay, you can ask the patient come after 2 days, and then after 2 days, or check at home. Now you see digital apparatuses everywhere.
Yes.
So then you can start. But if it is really high, then you will not say, okay, go home and come after 2 weeks or 1 week. Why? Because it is really high blood pressure. Second important thing, as we discussed last time, the drugs that we are discussing, all of them, they are used to treat essential hypertension. What do we mean by essential hypertension? That is also known as primary hypertension, where we don't know the exact reason. So that is called primary or essential hypertension. Now, there is relationship between hypertension and type 2 diabetes mellitus. Type 2. Type 2. No, one is not related with blood pressure.
Direct.
Direct relation between type 2 and blood pressure. 90% of the type 2 diabetes mellitus patients, they also suffer from hypertension, 90%. So you can understand such big number, they suffer from hypertension. Okay, go to the next group. That are the beta adrenoceptor antagonist. Again, we discussed them in general pharmacology. Here we will take some more details on it. First thing, we classified them into 3 groups. First one is non-selective, second one is selective, third one is again non-selective. In first, when we say non-selective, that is for the beta blockers. As you know, beta blockers, they are of 2 types, beta 1 and
Beta 2.
beta 2. Beta 1 receptors are predominantly present in the heart. Beta 2 receptors are predominantly present in the lungs. Okay. So if the drug is acting on beta 1 and beta 2, whether stimulating or whether blocking, here it is blocking beta 1 and beta 2 receptors, then we say it is non-selective. It is
Non-selective.
non-selective. And the very good example with us, that is propanolol. propanolol, lols. You will see all of them, they are lols. So propanolol, it is non-selective beta blocker. It will act both on beta 1 and beta 2. What is the target? Beta 1 or beta 2? 1. Beta 1 is the target. We want that the drug should only block beta 1 receptors. When beta 1 receptors will be blocked, what will be blocked? Adrenaline will be blocked to attach to its receptors. Okay? That is the target. Target in Arabic is hadaf.
No.
Target is this one. But what happens, like in case of propanolol, it will also block beta 2 receptors. So the adrenaline will not also stimulate beta 2 receptors in the lungs. But that is not the target. We don't want that it should block beta 2 receptors. Propanolol is prototype. Prototype means it represents the group. Like Anmar is prototype. It represents your group. Okay? So when we say propanolol, what comes to our mind? Beta blockers. Okay? So that is first thing. Second one, as we discussed that our target is beta 1. They are also called cardioselective. That they should only block adrenaline to bind to its receptors in the heart. So who are they? Like you see, the first one is atenolol, then metoprolol, then bisoprolol, and then nebivolol. Atenolol is written and then highlighted and then crossed. Why? Latest research says it is no more selective. It is no more selective. What does that mean? That it blocks both beta 1 and beta 2 receptors. If you take the book of pharmacology, it is still selective. But in 2023, they declared, based on the findings and evidence, that it blocks both beta 1 and beta 2. Okay? So, the one that more blocking beta 1 receptor is metoprolol, bisoprolol, and nebivolol. Okay? Propanolol is non-selective. Then we go to another group, and that is called non-selective beta 1, beta 2, and alpha 1 antagonist. It will block 3 receptors: alpha 1, beta 1, and beta 2 receptors. We know that alpha 1 receptors, they are predominantly in the blood vessels. Beta 1 receptors in the heart, beta 2 receptors in the lungs, alpha 1 receptors in the
Blood vessels.
blood vessels. Okay, who is that? Labetalol. There are other examples, but I took the example that is more relevant to us. So, now we have 3 groups: propanolol and atenolol, which are non-selective. Then we have selective metoprolol, nebivolol, and bisoprolol. Then we have again non-selective beta 1, beta 2, and alpha 1, and that is labetalol. You see, I wrote it in white and then highlighted it in
red.
You can say something like red or maroon. What is the mechanism of action? Mechanism of action is simple, that it will do 2 things. First, blockade of renal beta 1 receptors reduces renin secretion. As we discussed, beta 1 receptors are predominantly present in the heart, but they are also present in the kidneys. They are also present in the kidneys. So, in the kidneys, what it will do, that it will block renin. Who will tell me RAS?
Cross.
Yes. Not Arras. Arras is a famous city in Qasim, huh?
Yes.
Yes. RAS. Renin angiotensin,
System.
and the other A against
Aldosterone.
aldosterone. Renin, angiotensin,
Aldosterone.
aldosterone system. Renin, angiotensin,
Aldosterone.
aldosterone system. RAS. Okay. So this is a group of the hormones that plays important role in the regulation of blood pressure.
Which are angiotensin and aldosterone.
Yes. What happens physiologically when our blood pressure falls down? Physiologically, like all of you are, mashallah shabab, your blood pressure should be normal. But sometimes you see the blood pressure goes down. So when the blood pressure goes down, what happens? The kidney sends message. The kidney stimulates the hormone or the neurotransmitter renin that the blood pressure is going down. The CNS sends message to the kidneys, look, the blood pressure is going down. You might have discussed with Dr. Ayman the CNS or baroreceptors regulation of the blood pressure. I don't know and I'm not going into details. What is important for us? Blood pressure is going down. When blood pressure is going down, the message is going to the kidneys that the blood pressure is going down, do something. What the kidney does, it starts to secrete renin. And when renin is secreted, it goes into the lungs and acts on angiotensinogen. Angiotensinogen is converted into angiotensin 1. So, angiotensin 1 is converted into angiotensin 2. Now, try to understand. Angiotensin 1 is vasodilator. Angiotensin 1 is vasodilator. It will also cause the reduction in blood pressure. But what happens physiologically, why I am saying physiologically, this is normal, that angiotensin 1 is converted into angiotensin 2 by enzyme that is called ACE, angiotensin converting enzyme. Or if you ask Dr. Fathi, he will say kinase 2 enzyme. Okay, so angiotensin 1 is converted into angiotensin 2. Angiotensin 2 is vasoconstrictor. What type of vasoconstrictor? Potent vasoconstrictor. It will cause increase in blood pressure. It will cause increase in blood pressure. This is first thing. When angiotensin 2 is produced, or it is converted from 1 into 2, it will act in angiotensin 2 type 1 receptors. We will discuss later on. It will help to secrete aldosterone. What is aldosterone? Aldosterone is the hormone that acts in the distal convoluted tubule and collecting tubule to increase reabsorption of sodium and water. Increase reabsorption of sodium and water.
Sodium retention.
Sodium retention. Very good. So sodium retention means increase in blood pressure.
Yes.
So that is the natural phenomenon. Whenever our body, we feel that the blood pressure is going down, CNS sends a message to the kidneys, and by this way. So first, what it will do, it will block the beta-1 receptors in the kidneys, and by this it will reduce the blood pressure. Why? Because renin is the first step in the RAS, in the system that is responsible for regulation of the blood pressure. Okay, but this is minor side effect. Why? Because we discussed that only smaller portion of the beta-1 receptors, they are in the kidneys. The major action of the beta blockers, that is through heart rate. Why? Because it will block the beta 1 receptors in the heart. And when it will block the beta 1 receptors, it will reduce the heart rate as well as it will reduce the myocardial contractility. Contraction of the myocardium as well as the heart rate will be reduced. So by two mechanisms, beta blockers will reduce the blood pressure. First one by blocking renin, and second by blocking adrenaline to bind to its receptors in the heart. So that is the mechanism of action. Now we come to the indications. Hypertension with HD and HF. HD stands for
Heart.
heart, D,
Heart failure. HF. Heart failure.
heart failure, and D, simple,
Heart.
yes, high definition, HD. Heart disease and heart failure. So these are two different things. Heart disease may be ischemic, maybe angina, maybe myocardial infarction, while heart failure, it could be ventricular, it could be atrial, it could be congestive heart failure. So these are where the patient is suffering from heart disease or where the patient is suffering from heart failure as well as hypertension. So we use beta blockers. Second one, we use them for arrhythmias. Arrhythmias. Take arrhythmias. Take arrhythmias mean where the heart rate is high. Arrhythmia means irregular heartbeats. But there are two types of arrhythmias. One is bradyarrhythmias, where the heart rate is low, and the other one is tachyarrhythmias, where the heart rate is high. They are used in high or increased heart rate. That is the second important use. Third one, they are used in pheochromocytoma, OMA. Dr. Ali's favorite. Cancer, malignancy.
Benign tumor.
Benign tumor of the pheochromocytoma.
Chronic.
Pheochromocyte.
Of which organ?
Pheochromocytes.
Where are they? In
In the heart.
as adrenal medulla. Adrenal glands.
Ah.
Adrenal glands will secrete continuously adrenaline. Why? Because adrenaline is coming from adrenal gland. So we also use it in pheochromocytoma, and this is the use where it is definitely lifetime. We even cannot change to other drugs. The best option in pheochromocytoma is beta blockers. Okay, next is prophylaxis of
Migraine.
migraine. You will see sometimes patients in your clinic and the patient will tell you, doctor, I am using propranolol. And when you will go to the medical history, the patient is not suffering from hypertension, no blood pressure, no pheochromocytoma, no heart failure, no heart disease. Ask other doctor, why you are using propranolol? You are not suffering from any problem. So the next important thing, propranolol, metoprolol, atenolol, nebivolol, bisoprolol, they are also used to treat migraine. But how it will treat migraine? By prevention future attacks. It does not treat the acute attack. What we say abortive treatment. It is not abortive treatment. It is just to prevent future attacks.
Before
so,
the disease.
before.
Yes.
So it could be 3 months, it could be 6 months, it could be 12 months, like that. Mostly 6 to 9 months we use. So if you get question on your exam that non-hypertensive, anti-hypertensive use of beta blocker, where there is no blood pressure, and we use propranolol or any lol, then that is the migraine or migraine. Okay, the last one, that is HTN in pregnancy. You see, it is also written in white and highlighted in maroon, or red, and labetalol is also the same. So, keep in mind, drug of choice, DOC, doc, like your doctors. Yes, drug of choice in hypertension during pregnancy is labetalol. Drug of choice for hypertension during pregnancy is labetalol. The first option that we will take if there is no contraindication. What do we mean by contraindication? For example, the patient is allergic to loads, so then we will not use. Otherwise, it is DOC or drug of choice. Keep it in mind. Why? Because we will see there are also other drugs, they are used to treat pregnancy associated hypertension. But drug of choice is labetalol. The drug of choice is labetalol. Okay, so when you see a patient using labetalol, without any hesitation, you can say the patient is female, the patient is pregnant. That is the most important use of labetalol. Normally we don't use it. This is the special condition, and this is the condition where antihypertensive is used for specific period. In the beginning we discussed antihypertensive agents, they are used for lifetime. But this is the condition where we use it for specific period, 9 months, because pregnancy is 9-month project. After 9 months, baby is delivered, finished. Even if the mother is suffering from hypertension, after delivery, we will use other antihypertensive. During the pregnancy, the drug of choice is labetalol. Okay, now we come to the side effects. First one is bradycardia. Why? Because it will reduce the heart rate, because it blocks the adrenaline. Second one, it will cause bronchospasm. Why it will cause bronchospasm? Because it also blocks adrenaline in the lungs.
Yes.
So that is, keep it in mind. Then next it will mask hypoglycemia. Mask hypoglycemia. You know mask. All of us were using it during
COVID-19 pandemic. Yes.
Still some people use. Again, I think Saudi government issued this alert that you should use it in crowded places.
Yes.
So, Kamama.
Kamama.
Yeah.
Yes.
So, but here this mask is different. Hypoglycemia. You know hypoglycemia.
Yes.
Hypoglycemia, especially in type 1 diabetes mellitus. What is the normal level of blood sugar?
100.
100 to
120 to 80 milligram per deciliter.
yeah, that's all. 70 to 100 milligram percent. 70 to 100 milligram percent. So less than 60 will be hypoglycemia. Less than 60 will be hypoglycemia. Hypoglycemia is more obvious or clear in type 1 diabetes mellitus. Why? Because type 1 diabetes mellitus patients receive insulin, and insulin causes hypoglycemia. Insulin causes hypoglycemia. What is the problem with hypoglycemia? The patient tells you, doctor, I am going to be hypoglycemic, before he collapses. Sometimes he will collapse. So how he will tell you? There will be tremors. There will be tremors. There will be tachycardia, and then the patient will collapse. But what is the problem if the patient is taking beta blockers? There will be no tremors. Why? Because the beta 1 and beta 2 receptors in the skeletal muscles of the fingers, they are blocked by beta blockers. So there will be no tremors. There will be no tachycardia. Why? Because the adrenaline and the beta 1 receptors in the heart is blocked. So what is take home message? Keep in mind and tell me. Then next, rebound hypertension if suddenly DC. Washington DC? Yes.
If suddenly
DC.
decreased.
DC. You will find this very common in clinics. DC. DC this drug and start this drug. Discontinue. 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 That is very common in practice. You will see, inshallah, you will use this word like candies. DC. Discontinue. What is important? If the patient is taking beta blockers, he will stop it gradually. It may take 2 weeks, it may take 1 month to stop the beta blockers. Why? Because if you discontinue it, all of a sudden there will be rebound hypertension. All of a sudden there will be increase in blood pressure. Okay? So what is take home message? Discourage in bronchospasm. Who is bronchospasm patient? Bronchospasm in which patients? Asthma patients. Asthma. COPD patients. Respiratory patients. Any respiratory problems, there will be bronchospasm. We should not use beta blockers. Why? Beta blockers can worsen the symptoms. It can worsen the symptoms. Second, we should not use beta blockers in type 1 diabetes mellitus. Why? Because it can lead to serious problem. The patient will not be able to detect hypoglycemia. So take home message is they should be discouraged in asthma as well as in diabetes mellitus. Type 1 diabetes mellitus. Okay? Okay, go to next. Calcium channel blocker. Sorry, calcium is written in white, so it doesn't appear. Calcium channel blockers. CCBS. Calcium channel blockers. I know the chemical names are difficult and you don't need to recall. What you need to recall and also discussed in your PBL case, like amlodipine, nifedipine, diltiazem, verapamil. These are the few which are used. There are many, but these are few that we see in practice. Amlodipine is quite common. Even if you recall the case that you have taken last week, today inshallah you will complete. The drug that the patient was using, that was amlodipine. And amlodipine is calcium channel blocker. We discussed last time that calcium plays important role in the contraction of the muscles and cells. Okay, so mechanism of action: inhibit calcium channels in the vascular smooth muscle and myocardium. Vascular smooth muscles means in the blood vessels as well as in the myocardium in the heart. Okay, causes coronary and peripheral arteriolar vasodilation. Coronary means in the heart and peripheral, in the rest of the body. Verapamil, cardiac more than arteriolar. Its effect is more on the myocardium as compared to arterioles. Which one? Verapamil. Verapamil. You will see it sometimes in your clinics. The patient heart rate goes all of a sudden to 300. Yeah, doctor. 300 beats per minute. So the drug that can reverse it like anything is Verapamil. Verapamil will bring it down in seconds. Why? Because it blocks the calcium channels in the myocardium. Okay? Keep it in mind. Now, they are negative ionotropic and chronotropic. Who will help me from physiology? Ionotropic and chronotropic. Ionotropic.
The speed of contraction.
The speed of contraction is which one? Contraction of the heart or conduction of the heart? Conduction of the heart. Who controls the heart rate?
Control heart rate.
Yes. Yeah, doctor, we have just discussed. Yes. Who controls the heart rate?
Not.
Huh?
Not.
Parasympathetic.
Parasympathetic controls the heart rate. Sympathetic. In sympathetic,
Adrenaline.
adrenaline controls the heart rate. When you are sleeping and you are chased by a dog in the dream and your heart beats like anything, who comes first? Adrenaline. God forbid you make an accident, who comes first? It is not 9/11. This is adrenaline that comes first. So that is, and what about the electrical activity? Electrical activity of the heart starts from where? SA node.
SA node, yes.
SA node is where? In the heart.
In the heart.
In the heart where?
In the. You mean in one of the
The
valves?
name indicates SA node. Sino,
At,
China, huh?
yes.
Yes.
Sinoatrial. No.
Sinoatrial. So atrial means
Atrial.
atrium. So
Atrium.
it starts from the atrium. So ionotropic and then chronotropic. Chronotropic is electrical activity that is in the atrium. And ionotropic is, as you said, contraction of the heart. Which chamber contraction is important?
Left ventricle.
Left ventricle, very good. So it is ventricular. Ionotropic and chronotropic. Heart rate is controlled by adrenaline. Heart rate is controlled by SA node. That is called natural pace maker. Okay. So that they are negative ionotropic and chronotropic. They will reduce the heart rate and they will reduce the electrical activity. They will reduce the heart rate and they will reduce the electrical activity. Why it will reduce the heart rate? Because there is low calcium into the cells. Why? Because it will block the calcium. Okay? Good. Now indications. First indication is hypertension. Indication means uses. Where should we use? First one is hypertension. Then second one is
Angina.
angina or angina. Why angina? Because of its effect on the
Lungs.
lungs, yeah, doctor. Angina means Angelina Jolie.
Angina means in the
Pain
chest.
in
In the
the
chest.
chest.
Yeah, ذبحة صدرية.
But it is not due to lungs. It is due to
Heart.
heart. So angina pectoris. Pectoris means breast because this is in the breast of the left side. So the pain that is in the heart itself in the heart, in the coronary arteries and vessels, so it is called. So for this reason, because it acts in the coronary, it will cause vasodilation. For this reason, we use it in angina. There are types of angina, but this is not my scope. It may be physiology, pathology, or medicine. Next, arrhythmias, verapamil. What I told, you have a patient, the heart rate goes to 300 beats per minute. That is called supraventricular tachycardia. SVT are arrhythmias. So, who can be the best choice? Verapamil.
Verapamil.
Okay. Now, nifedipine, pregnancy-associated hypertension. But look here, we don't say that this is the drug of choice. We just say that it can be used in pregnancy-associated hypertension. So this is second line. Who is the first line?
Tremalol.
Labetalol.
Labetalol.
Labetalol is the first line. Labetalol is the drug of choice. Labetalol is the drug of choice. If you remember, I told, if for some reason the patient cannot take labetalol, for example, it causes too much decrease in the heart rate. So then what we will say, okay, we can try nifedipine. Nifedipine is second line, or what we say alternative, badil.
Yes.
So first one is
Labetalol.
labetalol. So if you have both of them in the MCQs, and the question is which of the following is the drug of choice? So the drug of choice should be labetalol. But if it is which of the following can be used in pregnancy hypertension, then it could be also nifedipine. What are the side effects? First side effect is headache. Remember, this will help you throughout your life. Any drug that causes vasodilation, any drug that causes vasodilation will cause headache. I am sorry to say, but I am telling. Even Viagra. One of the worst side effects of Viagra is headache. Why headache? Because it causes vasodilation. ها؟
يقولوا كان دواء قلبي.
وإيش دواء قلب؟ Viagra is دواء قلب؟
في البداية.
Yeah, it starts with antihypertensive. But what is the problem? Even with Viagra, headache. Headache, any drug that causes vasodilation will cause headache. Okay, next is bradycardia. But this bradycardia is less as compared to beta blocker. If you have option, which of the following causes more bradycardia? And the options are calcium channel blockers, ACE inhibitors, ARBs, and beta blockers. The calcium channel blockers cause less bradycardia, and beta blocker cause more bradycardia. Okay? Then we have ankle edema. Ankle. Not uncle.
Ankle.
So ankle edema, ankle means?
كاحل.
In this place or in this place?
This.
In the peripheral region, lower peripheral region. Accumulation of fluid.
Headache.
Yeah. Accumulation of fluid. Okay, thank you.
Yes.
Accumulation of fluid.
Yes.
Then nifedipine induced gingival overgrowth. Nigo.
Or Nigo?
Nigo. It is up to you. Even if you say Nigo, no problem. Why this is important? It interferes with the collagen in the gingiva.
Yes.
So there is overgrowth of the gingiva.
Yes.
And this is one of the reasons we don't use it for longer duration. Even sometimes it needs surgery. Why? Because the whole teeth, they are covered by gingiva. But you see, in pregnancy, it is only for specific duration, so we can use. But if you use it for many years, then it can lead to this problem, nigo or nijo, as you like. Okay. And the last one, constipation. Why it causes constipation? Because it blocks the calcium channels, and calcium channels are also in the intestines. So when the calcium channels are blocked in the intestine, what will happen? The intestinal motility is reduced. Intestinal motility is reduced. And intestinal motility reduced, there will be constipation. So that is the story of calcium channel blockers. Okay, now we come to this. We already discussed this. We will take just briefly and then go to the next. As we discussed, that there is a system that is called RAS, renin, angiotensin, aldosterone system. Now in this system, angiotensinogen by the action of renin is converted into angiotensin 1. By the action of kinase 2, angiotensin 1 is converted into angiotensin 2. At the same time, this angiotensin 2 converting enzyme, or what we say kinase 2 enzyme, it converts bradykinin into inactive peptides. Bradykinin is also vasodilator. Histamine, bradykinin, they are vasodilators. Okay, then what happens? Angiotensin 2 is synthesized. Now it will act on AT1 receptor and AT2 receptors. What is AT1 and AT2? Angiotensin 2 type 1 receptors and angiotensin 2 type 2 receptors. When it acts on angiotensin 2 type 1 receptors, it will also stimulate the secretion of aldosterone. So that is the story of the this. Now, first one in this ACE inhibitors, angiotensin converting enzyme inhibitors. There are two groups here. One is called the active molecules and the other one are called prodrugs. Active molecules mean they don't need any hepatic activation, what we say biological activation. Even we discussed it in general pharmacology. We have captopril and lisinopril. These are two that don't need any activation. The other one, fosinopril and enalapril, they are prodrugs. They need to go to the liver to be activated. What is important? If the patient is suffering from liver disease, like hepatitis, cirrhosis, then we will use only active molecules. Why? Because the liver is already compromised. So it may not be able to activate the prodrugs. Okay. Mechanism of action: inhibit ACE, prevent formation of angiotensin 2. We know that angiotensin 2 is potent vasoconstrictor. So it will prevent vasoconstriction and it will also reduce aldosterone secretion. So any mechanism that can cause increase in blood pressure, that will be blocked, whether it is angiotensin 2 or whether it is aldosterone. Okay, so here it will do one another thing. It will inhibit the breakdown of bradykinin. So the level of bradykinin will go up, and level of bradykinin go up means that there will be vasodilation, but that will be in the blood vessels. Just keep in mind, that is important for us. Bradykinin got two effects. One good effect, that there will be vasodilation in the blood vessels, but it will also accumulate in the respiratory tract. It will also accumulate in the respiratory tract, and that is the problem.
Accumulate what?
Accumulate bradykinin in the respiratory tract. So accumulation of bradykinin in the respiratory tract made it second line. ACE inhibitors was ruling like Saud family. They were the best by the cardiologist. You go to any cardiologist, any problem related with blood pressure, the first option is inhibitors. But what happened? This problem that it accumulates in the respiratory tract, what happens, I will tell you. Okay, indications. Initial choice for hypertension, but now question mark. Now it is no more initial choice. Previously, if you say some 10 years back, it was like anything. Any problem related with hypertension, even if you check your PBL case, the patient was placed on ACE inhibitors. But now it is changed. We should reserve where we cannot use others. What is the reason? We will see. Most effective in high renin patients, you will see some individuals where the patient produce more renin. So if the patient is producing more renin, there is more likely that the blood pressure will go up. But that patients are called renin sensitive patients. They are not many. But if the patient is like this, that the renin is being produced more by kidneys, then we can use. We can also use it in CKD and DM for renal protection. CKD stands for chronic kidney
disease. Chronic.
And DM for diabetes mellitus, not DM for direct message. Okay, diabetes mellitus and CKD for chronic
Kidney disease.
kidney disease. There is problem in both cases. There is proteinuria. Excessive amount of protein is going out from the body. So how we can protect? By giving ACE inhibitors. It protects the kidneys by this way. So it is called a renoprotective drug. Enhanced efficacy by diuretics, even sudden fall in blood pressure. We use it in combination with thiazide diuretic, furosemide, indapamide, chlorthalidone. As I told last time, you will see many times patient is using more than one drug to control blood pressure. Blood pressure is not so simple thing. You will see patients are using 5 drugs to control alone blood pressure. Forget about other things. It is so difficult thing. So it is used in combination and it can cause hypotension. The sudden fall in blood pressure is hypotension. What are the problems, side effects? Dry cough. Like this. This is the problem.
Okay.
And that bring it to second position. Why this problem? Bradykinin. Accumulation of bradykinin in the respiratory tract. The patient will tell you, doctor, my blood pressure is controlled, but now I cannot go to the mosque. Why? Because people say you are suffering from corona. Why you are coughing like this? So that is the problem. Sometimes the patient cannot sleep at night due to cough. So for this reason, now it has come to second line. Hyperkalemia. Hyperkalemia. It will cause potassium increase. That is the problem. Angioedema. Angioedema, like this lady. Although we don't know the exact reason that why it causes angioedema, some research says it could be genetic or idiosyncratic, but it causes angioedema. Although not very common, but not very less common. You will find sometimes patients, they are suffering from angioedema. Sometimes it is life-threatening. You see this lady, she is in the hospital.
Swelling.
Yeah, there is excessive swelling on the face and the eyes and bronchospasm. So that is problem. Maybe bradykinin is contributing, but we don't know the exact reason. But keep in mind, it could be life-threatening. It can kill the patient. So that is important also. Next is teratogenicity, fetal malformation. Absolutely contraindicated. You understand? Absolutely contraindicated. No way. If the patient is female and she is pregnant, goodbye to ACE inhibitors. We will not use. You see all of them, they are prils. Captopril, lisinopril, enalapril, fosinopril, pentopril, so many prils. All of them. Prints are absolutely contraindicated. Why? It can damage the fetus like anything. So, the patient is female, she is pregnant, she is hypertensive, we will shift immediately to labetalol, or in worst case to nifedipine or methyl we will stop ACE inhibitors. Why? Because it can damage the fetus. Okay? The last one, Arabs, but not Saudi Arabia. Angiotensin receptor blockers. Angiotensin 2 type 1 receptor blockers. Angiotensin 2 type 1 receptor blockers. They are sultans. I used to joke, they are not shaitans. Losartans, valsartans, olmesartans, telmisartans, all of them, they end by the suffix sartans. Okay, mechanism of action, as we discussed in the beginning, it blocks AT1 receptors. What we say AT1 receptors, angiotensin
Type
2,
1.
angiotensin 2 type 1 receptors, angiotensin 2 type 1 receptors. These receptors, they are blocked. Angiotensin 2 is synthesized, one is converted into 2. Next step that it should come and stimulate these receptors. Now, what we will do, we will block at this stage. Block at this stage. So that is angiotensin 2 type 1 receptors. Sometimes confusing. Okay. Where are we going? Yes. So, by this way, it will prevent formation of angiotensin 2. Why? Because angiotensin 2 is formed, but it will not bind to its receptors. That is responsible to cause increase in blood pressure. It will also reduce aldosterone secretion. Why? Because these are the receptors which are responsible for the secretion of aldosterone. So, it will inhibit, where are we? Here. There will be second vasodilation and decrease aldosterone secretion. But there will be no effect on the bradykinin. Why? Bradykinin is here and that is already done. Here we didn't block the enzyme that is responsible for the conversion. One is converted into 2. But what we are doing, we are blocking it at this gate. Don't come from gate 1. Go to gate 4. Okay? So, we are blocking the entry point. Everything is done. You reach to Qura, but when you come to gate 1 is blocked because someone is coming. Maybe VVIP is coming. So the same, 1 is converted into 2, but when it goes to its receptors, we block that receptors. But what happens that it has no effect on the bradykinin. So what happens? Bradykinin is converted into inactive peptides. And what is the benefit when it is converted into inactive peptides? There will be no
effect on bradykinin.
On the cuff. There will be no cuff. Why? Because there is no effect on the bradycardia.
Yes.
So, indications. First line for the HTN. You see, it has replaced ACE inhibitors. So, if you get question on your exams, which of the following has replaced ACE inhibitors as first line for hypertension? Arabs. So, you have replaced Iran or maybe Israel.
Replaced what, doctor?
Replaced ACE inhibitors. Which of the following replaced ACE inhibitors as first line treatment? Karan is happy when there is Israel and Iran. Okay. Especially with compelling conditions. As I told, many times you will find patients, they are suffering from comorbidities. They will be suffering from diabetes, they will be suffering from heart failure, hypertriglyceridemia, hypercholesteremia, and this, that. Like DM, HF, and CKD. Diabetes mellitus, heart failure, chronic kidney disease. So in that conditions, we will definitely start with Arabs.
Arabs.
Chronic kidney disease. Okay? So, other side effects or adverse effects are same except
Cough.
cough.
Because no effect on
No effect on the
bradykinin.
bradykinin.
Yes.
So that means that the angioedema is not due to bradykinin. Angioedema is not due to
Bradykinin.
bradykinin. This, where it gone? This angioedema, that may be due to some other. Because sartans also cause angioedema. Sartans also cause hyperkalemia. Sartan also cause teratogenicity. So what is take home message? That we will not use it in
Regulatory.
pregnancy. Same, ACE inhibitors and ARBs, both of them, they are not used in pregnancy. Here one another thing came. Olmesartan associated enteropathy. Olmesartan associated enteropathy. This is a story of some 10 years back, a real story. Olmesartan is long-acting sartan. It is long-acting ARB. You need to take once a day. You need to take once a day. So what happened? A female patient, she was 85-year-old. And she was switched to olmesartan. Why? Because she complained to the doctor, doctor, my blood pressure is controlled with lisinopril, that is ACE inhibitor, but I cannot sleep at night due to dry cough. So the doctor said, okay, we have new drug that doesn't cause cough.
Arabs.
Arabs. And olmesartan, because she was elderly lady, 85 years, she may get confused if you repeat the dose. So just take in the morning or just take at night, khalas. You don't need to repeat the dose. What happened? After 3 months, she came back to the doctor. Doctor, my cough is gone, but now I'm in another problem. Now my stomach flu starts. What is stomach flu? Diarrhea.
Diarrhea.
So then research starts. What is going on? They came to know, oh, it can damage the intestines. So be careful while prescribing olmesartan for elderly patients. It can cause diarrhea. And the diarrhea that does not respond to any anti-diarrhea. You will try different antidiarrheals, but diarrhea will not stop. When it will stop? When you will do DC. What DC? Discontinue. Discontinue olmesartan. You will DC olmesartan, the diarrhea will go. It will not go with drugs. So that you should keep in mind. As we know, it is teratogenic, so don't use in pregnant women, and we don't use it together because both of them, they act on the angiotensin II. So that is the story of entire hypertension.